Having a family is part of the natural order of things that many people imagine for their future. Many couples assume they'll have kids. Many men figure that one day they'll get cards for Father's Day. But a surprising number have trouble achieving that dream. Infertility is remarkably common.
Infertility affects about 1 in 8 couples. In the last year that we have information, 7.5 million people have used infertility services.
That's Dr. Arthur Wissett, professor of obstetrics and gynecology at the UCLA School of Medicine and the Reproductive Partners Medical Group.
We really don't know how many people are really suffering from infertility because it's not something people usually go and talk about. And many people don't go for treatment because they're ashamed or they don't want to have to deal with the medical issues or they're afraid of the costs. And they don't realize that most of the people that walk in our office with an infertility problem can have it solved fairly simply.
We see many patients in their second, third, fourth, fifth, sometimes 10th year of trying before they come and see a reproductive specialist.
And the odds of infertility are increasing, according to Dr. Barry Baer, professor of obstetrics and gynecology and lab director of the Fertility and Reproductive Health Program at Stanford University.
Due to social pressures and just changes in our cultures, the age at which women embark on childbearing or procreation has been protracted or moved later on in years, which has really resulted in the likelihood of infertility becoming a factor for a couple increasing.
Wissett says a couple is considered infertile if they've been unsuccessfully trying to conceive for a year.
We've modified that over the years because we realize that people in the older age group, maybe above 35 to 37, probably should come in sooner, because if they keep trying and trying, they will be wasting time. And we really need to do an evaluation to see if there are any issues which can be corrected to get them sooner rather than later. If you ask a specific couple when they would consider themselves infertile, they probably would tell you the first month they tried and didn't succeed. They would be worrying about this.
When the problem causing infertility isn't so simple, doctors often turn to in-vitro fertilization. IVF is far from rare anymore. Since Louise Brown, the first test tube baby, was born in 1978, she's been joined by about 5 million more. But only around a third of IVF attempts result in a live birth. Younger women are much more likely to succeed.
The most important factor that affects the success rate is the age of the woman. If you look at the average success rates in the United States, looking at 2013, a total of 175,000 cycles of IVF were performed in the U.S. in 2013, resulting in about 65,000 live births. And if you look at the difference in live birth rate, on average, if a woman was under 35, she would have a chance of a live birth in 42.5% of retrievals, or 47.7% in transfers of embryos. When she gets into the age group of 35 to 37, the live birth rate per transfer goes down to 39.2%.
And in women older than that, the numbers go down quickly. But with the clock ticking and an average cost of $12,400 per cycle, there's a lot of incentive to make IVF work the first time and make sure an embryo sticks.
When we first started with IVF, we didn't have very sophisticated ways of knowing which embryos were really the best. And so we had to place back into the uterus larger numbers of embryos. It was not unusual to be putting 4 embryos into a woman's uterus, even at young ages. And we ended up with a high incidence of multiple pregnancy, twins, and even triplets and quadruplets.
The problem of multiple births from IVF is the black eye that our field has, unfortunately. And the reason we replace more than one embryo at a time is to attempt to increase the odds of a single embryo implanting. There is never an intention when we transfer more than one embryo to create more than one baby at that particular cycle. Humans were not designed to carry litters. We were designed to have one baby at a time, and any time there's a condition that would result in a pregnancy being shorter than the ideal 39 weeks or so, as would be the case with multiples, it generates a suboptimal condition for the baby's born and as well as the mother, potentially.
Triplets and quadruplets are 36 times more likely to die within about a month of birth compared to single infants, according to a study in the journal JAMA Pediatrics. So medical guidelines in the United States were changed in 1998 to discourage transferring 3 or more embryos. And since then, Wissett says the average number transferred per IVF cycle has dropped to 1.8. But even that is higher than Wissett and Baer would like it. IVF still results in twins about 30% of the time.
Problem with twins is everybody says, well, I really like twins, then I can get all my childbearing done at once. Well, a twin pregnancy is a more dangerous pregnancy, more prone to premature labor, which will mean either an immature or premature baby that'll have to spend time in the NICU and can have breathing problems and feeding problems. And really what we want to give a couple is a healthy single baby. The incidence of triplets, though, dropped to less than 1% in women under 35 in 2013. So we are doing a better job of eliminating the higher order multiple pregnancy, triplets, quadruplets, still getting too many twins. And so what we really want to do is make almost every embryo transfer a single embryo transfer, especially in young women.
Despite trying to convince patients that we would prefer to transfer one embryo at a time, many couples want twins. It's a novelty. It's having your family 2 for the price of 1, if you will, when you're going through IVF. So we have to do a lot of education and sort of legwork, if you will, to many times convince patients that one at a time is the way to go, even though we can provide data to show the benefits of having a full-term healthy singleton versus a preterm twin delivery. Many people, I think, like most things, don't think anything's going to happen to them. This wouldn't happen to them. This happens to somebody else.
The challenge for IVF doctors, then, is how to transfer just one embryo and still guarantee a good chance that it'll implant and result in a pregnancy. The key is the quality of the embryo. Some are more viable than others and more likely to implant. And now doctors have a better chance of figuring out which ones those are, thanks to a test just approved by the FDA called EVA.
So the EVA test is a time-lapse microscopy system that provides an embryo diagnostic through an algorithm that was developed with myself and 2 colleagues at Stanford, which allows embryos' morphokinetics to be quantified. And the quantification I'm referring to really is the actual measurement of the cell divisions, the first few cell divisions of the embryo during its first 2 or 3 days in culture in the IVF lab. And there are inferences that can be made about the embryo's potential based on how they divide, how fast they divide, how synchronously they divide.
EVA is the first test of its kind, which uses time-lapse video along with time-lapse evaluation by the computer to observe the exact moment of division of the first cell, to get from 1 cell after fertilization to 2 cells, then to 4 cells, then to 8 cells. And studies have shown that it is in a very narrow range of time to be able to say this embryo is a viable embryo. And this time-lapse image analysis software is really what makes EVA so special.
Baer says EVA can reliably separate embryos with good potential from those with less.
Now remember, the potential is not absolute. It doesn't mean that if you have a low potential that it's 0, or that if you have a high potential that you're absolutely going to make a baby. But it really is an additional tool that I believe already has, but definitely will in a greater capacity, change the confidence and the comfort level that practitioners have to be more commonly transferring single embryos.
When they took the embryos that were examined by EVA and they gave a panel of 5 embryologists the embryos to look at the shape and the number of cells, the standard way we evaluate embryos, and then did the standard number of embryos but added the factor of which EVA said had the highest chance of implantation, the ones that were selected by EVA were 58% more successful than the ones just selected by the embryologist in the standard way. So I can tell a patient who is in her 30s and has been trying for 4 years and comes in, does an IVF cycle, has quite a few embryos, and says to me, well, I'd like to put 2 back because I really want this to work, I can say, with the reassurance I have from Eva, I can put 1 embryo back and give you a really good chance of success.
For some couples, that reassurance is enough to finally go ahead with IVF after years of infertility. For example, Courtney Kinney of Walnut Creek, California, and her husband Michael wanted to be aggressive with treatment after 2 years of infertility, but they had medical reasons to avoid a multiple pregnancy. They're now proud parents of an 8-month-old boy.
It was actually going to be very dangerous if I were to get pregnant with twins. We found out that I have a short cervix, so the likelihood of having complications with twins was very high. So with the EVA technology, it was very comforting knowing that we were selecting the right embryo for transfer, since we'd only ever be able to transfer 1 embryo.
Even though EVA adds cost to the IVF procedure, Baer says it ultimately should save couples money because the necessity of a 2nd or 3rd IVF cycle will often be eliminated. And while older women still typically have multiple embryos implanted today, he hopes that practice will end soon, too.
The guidelines are to transfer a single embryo if you're under 35. But I'm just going to report to you, because I have these in front of me, only 22.5% of cycles under 35, for women under 35, had single embryo transfer. So what you're quoting is what the guideline is, but what is actually practiced is far from that. So what we're hoping for is to allow people to follow the guideline with a greater degree of comfort and less impact on the outcome. So that's the power of the technology.
So while the proportion of twins has doubled over the last 40 years, mostly due to IVF, that could start to decline. Triplets have already declined by about 30% in the last 15 years. Families with IVF kids should start to look a little more like every other family, but with parents who can thank technology for being parents at all. You can find out more about EVA at evatest.com. That's EEVA test.com. You can find out more about all of our guests and find archives of our programs on our website, radiohealthjournal.net. You can also find archives on iTunes and Stitcher. I'm Reed Pence.
There's growing evidence that people can reduce their risk of cognitive decline by making key lifestyle changes. That's why during June, Alzheimer's and Brain Awareness Month, the Alzheimer's Association and its experts are sharing 10 ways to love your brain, evidence-backed tips that may reduce your risk of cognitive decline. Here's Angela Geiger, Chief Strategy Officer of the Alzheimer's Association.
First, break a sweat with regular exercise. Hit the books. Formal education at any stage of life reduces your risk of cognitive decline and dementia. Butt out by quitting smoking. Then follow your heart, because cardiovascular disease risk factors such as obesity, high blood pressure, and diabetes also negatively impact your cognitive health. Finally, make sure to fuel up right with a healthy diet and catch plenty of Z's.
Research suggests that combining all 10 tips offer a greater benefit to brain health than any single activity alone. Find out all 10 ways to love your brain at alz.org. That's alz.org.